Good afternoon, everyone. My name is Dr. Dominic Akateba. I work with Ghana Medical Health. You are welcome to this afternoon's presentation on the Partograph. We thank you for joining us for today. Midwife Dinah Norte will be leading us with this presentation on the Partograph. As much as all of us who work in the maternity unit or practice obstetrics, we definitely know that the good old Partograph is still with us, especially in the developing world. We are well aware of the WHO tool that is also available, but definitely lots of us, especially as a country, Ghana Health Service, Ministry of Health, we've not fully transitioned to the WHO tool. So most of us still make very good use of the Partograph. So it's good to remind ourselves of this all-important tool. Midwife Dinah will be leading us with this presentation. By way of housekeeping rules, you notice that if you try to unmute yourself, you'll be unable to. This is to prevent people from inadvertently unmuting themselves. However, the chat box is available. You can make use of it. If you have a question, a comment, whilst the presentation is ongoing. However, at the end of the presentation, which we are hoping will last about 30 minutes, we'll have a good time for questions, comments, contributions towards making this discussion an excellent and a legendary one. Thank you so much for joining us once again. Midwife Dinah, the floor is yours. Your participants are waiting for you. Thank you. Bye.
Good afternoon, everyone. My name is Dinah Norte, midwife at the West District Hospital. So our topic for the day is Partograph. So this is the outline of the presentation, our introduction, history, objectives, function, components of the Partograph, contraindication, the outcome, and conclusion. So we say that the Partograph, it is a graphical representation of all the monitoring that we do for a woman in labor. Everything you monitor on the baby, everything you have monitored about the progress of labor, then the maternal condition. So the Partograph, it can be in the form of the paper, and it can also be electronic if you find it on the computer. So how did the Partograph came into existence? So in the year 1954, Dr. Emmanuel A. Friedman was a obstetrician gynecologist who came about just cervical dilatation, position of fetal head against time. That was the only thing he brought into existence. Then later on in 1973, Philpott and Castle also brought about the alert and action line. So with this, WHO picked it up and developed it into the complete Partograph that we see today in our various labor wards. And it has come into existence for monitoring of our labor cases. So the objectives of the Partograph, what the Partograph seeks to achieve, the results that we want. First of all, we are saying that for early detection of abnormal progress of labor cases, we want to also prevent prolonged labor when we are using Partograph. The Partograph will also help to recognize CPD, cephalopelvic disproportion, even before the labor become obstructed if we are using it correctly. Again, it assists in early decision-making on transfer of clients or augmentation or termination of labor. So on transfer, those working at the health center level, it will give you the clue that you need to transfer this woman to the next level. If you're also at the hospital level, you take a decision on either augmentation or cesarean section. Also, it increases the quality and regularity of all the monitoring we do on the mother in the fetus. Because there is time durations design on the Partograph. You can't just monitor the labor at the time you want. You are expected to check something within every 30 minutes before you go and put in your results there. So it ensures quality monitoring. And also early recognition of maternal and fetal problems, such as fetal distress, maternal distress. And went ahead to say that the Partograph is also highly effective in reducing complications from prolonged labor, such as postpartum hemorrhage, uterine rupture, fetal anosmia, infections, and even fetal death. So the function of the pathograph, depending on the level you find yourself, its function will differ a little. So we are using the alert line for the health center level and the action line for the hospital level. So the function of the pathograph at the health center level, when your graph, when you plot and you crosses the alert line, you should start thinking of referring this woman to the next level. You wouldn't wait till you get to action line before you think of transferring the woman. But when you are at the hospital level, when you get to an action line, it means that an intervention must take place. And even with that, if you're at the hospital level, when you cross the alert line, you should start asking yourself questions. What could be the problem? You can even identify the problem way before you even get to the action line, so that you know what exactly you are going to do for the woman once you get to the action line. So what are the components of the pathograph? When we talk of the components of the pathograph, there are three main components. We have the fetal condition, maternal condition, progress of labor, but other things are also on the pathograph. So first of all, what you see on the pathograph, you see the maternal identification information, name of client, hospital number, gravity, parity, day, time of admission, then time of rupture of membranes. You fill out the information appropriately. Then you come to the fetal condition. It is arranged in that order on the pathograph, if you have one with you, but we will see pictures later on. We'll see what we are talking about. So when you get to the fetal condition, we are monitoring fetal heart rate every 30 minutes regularly and recording the values. So we are saying 120 to 160 beats per minute is the normal fetal heart rate. If you're having above 160, it means you're having fetal tachycardia. If you're having below 120, you're having fetal bradycardia. If you check and it's abnormal, you check again. You wouldn't wait for 30 minutes before you check it. You check again, maybe in 5 minutes time, 15 minutes time. Then consistently, you are getting above or below the normal value. And you can say there is a problem. If you get below 100 beats per minute, it means there is severe fetal bradycardia. Then the appropriate intervention will have to be taking place. Then, still under fetal condition, we come to talk of the amniotic fluid. You have to indicate on the pathograph, at the time you did the vaginal examination, was the amniotic membrane intact or ruptured? If it is ruptured, is the fluid clear? So here on the pathograph, since we are talking about so many things, you can't go and write everything on the pathograph. So the plotting is denoted with some symbols, some letters that stand for a whole sentence or a whole word. So intact membranes, for instance, you indicate it with the letter I with its corresponding time. So when membranes are ruptured, you indicate is the liquor clear. If liquor is clear, you are indicating with the letter C. If membranes ruptured and it's meconium stain, you will represent it with the letter M. Membranes ruptured with blood stain, you indicate it with the letter B. If membranes ruptured but absent liquor, you indicate it with the letter A. And anyone who understands the pathograph can easily interpret it as such. So still under fetal condition, you are also going to ascertain the molding of the fetal head. And this molding will give you a clue as to whether the fetal head, the pelvis can accommodate the fetal head, or the fetal head can adequately pass through this pelvis. So when you perform your vaginal examination, mostly when membranes are ruptured, that you can ascertain this molding very well and say there is no molding or there is excessive molding. So if, in order to identify or to know your molding, you have to feel the sutures with your fingers, your examining fingers in the vagina. So when the bones can be felt easily, and separated, you represent it with 0, meaning molding have not taken place yet. If the bones are touching each other, then you represent it with 1+, meaning there is slight molding. Then if there is overlapping bones, you represent it with 2+, and it's reducible. Reducible means if you try separating the bones, try sliding the other bone, it can be separated. So that's 2+. If it is severely overlapped, then it will be represented with 3+. And that one, sometimes you'll be thinking of a caput, you'll be thinking of CPD, even though it's not always the case. But if you have severe molding, probably the head is struggling to pass through the pelvic outlets. So now we come to the progress of labor. So when you take the partogram after fetal condition, the next information you have will be your progress of labor. And under the progress of labor, we have cervical dilatation, descent of the fetal head, then uterine contractions. So when we come to cervical dilatation, we are saying, before you use the partograph, it means this woman might have been in the active phase of labor. And 4 centimeters and above, dilatation of 4 centimeters and above tells you that this woman is in active stage of labor. Also, you should have like 3 contractions in 10 minutes. And then each contraction lasting over 40 seconds. These are the normal parameters that will tell you that this is active labor. That is all other things being equal, even though it's not always the case. Not everyone in active labor will be having 3 in 10 contractions and the contractions lasting over 40 seconds. But that is the normal thing. So the cervix is also expected to dilate at 1 centimeter per hour or faster. And again, it's not always the case, but that is the ideal. So cervical dilatation is represented with the letter X, the X sign. You plot on the line X, indicating your cervical dilatation. At the time you have performed your V, and the next 4 hours time you perform V, or when V is necessary, you plot your cervical dilatation with the appropriate sign on the appropriate corresponding time. Then we talk of descent of the fetal head. So we want to know whether much of the fetal head have entered the pelvis or much of it is in the abdomen. So we use the rule of feet. So that's how come you hear 5 feet, 4 feet, 3 feet, 2 feet, 1 feet, 0 feet. So if you palpate abdominally, we midwives, those of us who do the abdominal palpation, we use our fingers. So our fingers are 5. If much of the fetal head is abdominally, you'll be able to feel it. And the number of fingers that are able to occupy that part of head you felt abdominally, you use that to determine the descent of the fetal head. You can also do it vaginally using the symphysis pubis or even the ischial spine. You perform V, you realize that your fetal head, it has even come down at the level of the ischial spines or beyond the symphysis pubis, and you realize that much of the fetal head is in the pelvis as compared to that of the abdomen. And you'll be able to know that this is 3 feet, this is 4 feet, 0 feet. So actually, if the whole head, the head has not entered the pelvis at all, that is why we say 5 feet. Not even part of the head has entered. So if it has entered a little, it's 4 feet. So in that order, when the head finally enters the pelvis, almost at delivery, let's say in the vagina, we say 0 feet, meaning the whole head is now in the pelvic cavity. And then you plot it using the letter 0 or circle, any of them. Anyone picking the partogram know that this is head descent. Then we go to uterine contractions, still under progress of labor. So we are recording the frequency, duration, and intensity of the contractions. And the contractions is also timed every 30 minutes throughout until the woman delivers. And you are checking contractions over a period of 10 minutes, and it is measured in seconds. So during the period of 10 minutes, each contractions that you were able to feel on the woman's abdomen, you should know how many seconds it lasted. So when you pick a pathograph and a woman who came with contractions of less than 20 seconds, it is denoted with dots. You see dot, 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 dots, whether 2 boxes. So if it was too intense, you see 2 boxes will be occupied with those dot dot. If it was 3 intense, you see the dot. If it is between 20 to 40 seconds, it is represented with strokes. So you pick a pathograph and you see that they've used stroke to design those boxes. It means the contractions were between 20 to 40 seconds. Then when the contractions are above 40 seconds, then we use shading. We shade it deep to indicate that these contractions are above 40 seconds. And usually if the woman is in active stage of labor, it is expected that the contractions should be above 40 seconds, but it's not always the case. So we are done with the progress of labor. We are going to maternal condition. So maternal condition is basically about the vital signs, urine output, drug administered. Vital signs are checked every 4 hours, and then you plot it on the corresponding time. And then urine output, you check your protein, you check your acetone. Then if any drug was administered to this woman, there's also a space on the pathograph, which you will see later, that you will record everything there, be it IV fluids, oxytocin, antibiotics, and so forth. Then we have alerts and action lines. You will see alert and action lines in the middle. That is where progress of labor is. So the alert line, diagonal line, indicating the expected rate of cervical dilatation. So if your progress of labor is good, you realize that your line will be along the alert line and not going beyond it. And then we have the action line, which is also parallel to the alert line, which tells you that when you get to an action line, an intervention must be taken. But with this, we are saying that it is expected that correct plotting of the pathograph and also the correct monitoring that we did on the woman, timely monitoring, regular monitoring. Most of the time, if we don't do correct monitoring, we will get to the action line and we will get a problem for the woman where there was none. Example is the cervical dilatation. Maybe the woman did not really get to 4 centimeters. Then we estimate cervical dilatation, you enter with your fingers and you give an estimation. And people have different sizes of fingers. So maybe the woman was 3 cm, but I estimated she's 5 cm. And then I pick my pathograph, I have started. Then I get to action line. The woman have still not delivered. Then at the end of the day, we will take an intervention that was not really necessary for this woman. So if we can get it correctly, we have to ensure that the pathograph, the information on the pathograph is really reflecting what is happening to the woman. The labor is, the cervical dilatation is really 5 cm, and that is what you see on the pathograph. Otherwise, we'll always get to action line. We start calling our doctors when the woman really is not having problem or the labor do not really have any problem. So here is a sample of unused pathograph and the information that we talked about previously. You see the information at the top, followed by the fetal heart rate. If you understand it, it's user-friendly. They've written everything boldly. Fetal heart rate with the fetal heartbeat, the ranges, every value you have, you will get a place to plot it with the appropriate symbols that you are supposed to use. So the next samples we are seeing, they are samples of plotted partograph. The one on the left, Madam X, the one we've written on it, Madam X, that one was made purposely for this session. So you realize that Madam X was admitted at 10 o'clock a.m. with a cervical dilatation of 5 cm. But when you go to the contractions, you realize that she's having contractions less than 20 seconds. And then you have to ask yourself, person, a woman who is 5 cm dilated, is she supposed to be having contractions as low as less than 20 seconds? No. So we swept membranes for this woman and we continue. Then the contractions went to a range of 20 to 40 seconds, 3 in 10, lasting 20 to 40 seconds. Then we realize that if we do not do anything about these contractions, this woman labor will prolong unduly. So the decision was taken to augment. So we augmented with 0.5 units of oxytocin in 500 mils of normal saline. So on the partograph, you see a place they've written, moving to the downward part, they've written drugs given and IV fluids. That is where we indicated what exactly you gave to the woman. So you realize that after we gave the oxytocin in normal saline to this woman, the intensity of the contractions have increased, even though the number is still 3 in 10, but the intensity have increased. We are getting over 40 seconds, 3 in 10 over 40 seconds. And the next when we check the cervical dilatation, it is moving in the normal direction. So got to 9 cm. It means the labor is moving, progressing normally. So in this case, if you know that uterine contractions are ineffective and you do nothing about it, you definitely get to the action line. And then we start calling each other that the woman, the progress of labor didn't go well. So we should do something. Whilst we could have done something way long, even before we get to the action line. So the next one is a normal partograph that the woman delivered. She came with 4 cm, delivered just within 3 hours. It is possible. Then the other ones we are seeing, you see that someone who can come, she have good contraction, but to take a number of hours before the person delivered. The one on the right, you realize that the last dilatation plotted against 10, if it delayed a little, it would have got to the action line. So these are some of the samples that we can use to identify the normal or abnormal monitoring of labor representing on the partograph. So we are saying that it's not every case that we use partograph, not every labor case that we will use partograph. When a woman gets to the labor ward, you have assessed this woman, she's already 10 cm dilated. It means that's second stage of labor that she has already approached. You don't need to continue monitoring a labor when she's already 10 cm. Then a woman who presented with immediate complications that need immediate intervention. Example, placenta previa, cord prolapse, massive hemorrhage, etc. We need to do something immediately to save mother or fetus or both. So the outcome, at the end of the day, we should know the outcome of the labor that we're monitoring. Did the woman progress normally, progress well and delivered? Did we augment the labor? Was there the need to do cesarean section? And then the findings, what were the findings? So you document your findings on the partograph. So whether it was a CS, whether it was a vaginal delivery, the time, the baby findings, and all the necessary things that need to be documented on the partograph. So in conclusion, we are saying that when we are considering partograph use, it is crucial to ensure proper training, accurate documentation, timely intervention based on the graph's finding, to prevent complications like prolonged labor, obstructed labor, ultimately improving maternal and perinatal outcome. So this is the end of my presentation. Thank you very much for your audience, and welcome any contribution, questions, any relevant literature that we can also add. Thank you very much.
Great. Excellent. Thank you so much for an excellent presentation. So we'll open the floor. Electronically raise up your hand, and then if you have a contribution to make, I can go ahead to unmute you, and then you make the contribution. Whilst we wait for that, Dr. Gildas, the obstetrician gynecologist and head of department of ONG in our hospital, Upper West Regional Hospital, is on the call. I'll probably have some few contributions to make. Dr. Gildas, the floor is yours.
Yeah. Yeah, thank you, Dominic. Yeah, Dinah, you've done very well. Your presentation is very concise and straight to the point and very simplified. In fact, it's like the pathograph you just presented. And as you rightly said, it's a simple tool for labor monitoring that monitors both the mother and the fetus. So some of the advantages will include early detection for abnormal progress of labor. And then this will lead to prevention of prolonged labor, as you rightly said. If the contractions are not adequate, you augment. If you recognize that there's about to be CPD, if there's molding, caput, you also refer. And it will assist in early decision to refer, to augment, or to terminate labor. When I say terminate labor, it means to do cesarean section. So this is a tool that was adopted by WHO, and it has led to a lot of prevention of obstructed labor among so many women. And I actually encourage all midwives to learn how to use it. It's very simple, and I mean, it's self-explanatory. If you look at the photograph, there's a place for the mother, there's a place for the fetus, and all you have to do is to monitor and know when to intervene. Of course, if you are in the peripheries and it becomes abnormal, you need to refer for them to take to a place where possibly they have a theater so that they can take it from there. Yeah, so we'll open the floor for questions and contributions if you have any.
Great. So we wait for questions, contributions, or any of that. If you have questions, contributions, kindly electronically raise up your hand, and then I can go ahead and unmute. Naya's iPhone, you can go ahead and unmute yourself. I think you have a question. Since we have time, we can talk. So just feel free, unmute yourself, and then you can go ahead and ask the question. Just electronically raise up your hand or unmute it. Nice. Naya. Yeah, so Naya, please unmute yourself and then go ahead and ask your question. I've asked you to do that. Naya's iPhone. Okay, doesn't look like it. Naya wants to talk. Anyone with any question? Yeah, so there's a hand up. Luanga, please go ahead. That Dr. Charles Luanga, go ahead and unmute yourself. I've asked you to.
Yes, boss. Thank you very much. Good afternoon to you and a wonderful presentation. I want to find out some clarification on fetal heart rates. I think I saw somewhere in the presentation 120 to 160. Some literatures have 110 to 160, others put 110 to 170. So I don't know if some clarifications could be made on that. Thank you.
Yeah, so I think for the purpose of this presentation and for everyone online, we should stick to 120 to 160. I think there was a time when warehouse officers, it even came around that, yes, the fetal heart rate can be as low as 110 and then go to 180. But I realized that there were a lot of issues with that. Many babies were being delivered asphyxiated. So it was brought back to 120, 160. Actually, it just shows that there's something going wrong with the fetus. So normally outside, what they do is to do the fetal scalp pH. If it is less than 7.2, then it means the baby is distressed. But our settings, we don't really have that. So after resuscitation, if the fetal heart routinely is above 160 or below 120, we tend to section. And if you've noticed, Dr. Loanga, you've done so many CSs, you realize that the babies come out with Apgars of 8 and 9. So unfortunately, we can't wait for something to go wrong. So we tend to normally take action before anything will go wrong. So, but if we had a fetal scalp pH, the ability to check that, fine, but we don't have that ability. So let's stick to 120 to 160. It just means that it should be alert. What are you doing that is making the fetal at high or low? Are you putting on some oxytocin? Is she lying on her back? Then it means that I also have to give her some IV fluids as well. If it still maintains below 120 or goes above 160, then you have to act. If she's far from delivery, cesarean section is the option. But if she's fully dilated, there's a quicker way of delivering this fetus, which is through vacuum delivery. Okay. Dr. Luanga, is it answered?
It doesn't look like Dr. Luanga, he's muted himself as well. So if any more questions, or Dr. Luanga, if you are there, you want to still talk, fair enough. Yeah, so he's answered that, he's answered. If you have any further questions, please unmute yourself and then have a go. Any questions? Just electronically put up your hand. I'll mute you to go ahead with your question. Still shy. Okay, Matilda, please go ahead. It doesn't necessarily have to be a question. It could be a comment, a contribution. We're happy if you give a different perspective or any of that. Matilda, you have to unmute yourself and then go ahead. I've asked you to do so.
Okay, good afternoon, sir. And thank you for the opportunity. Please, I want to find out, in a case where the woman have ruptured membranes in the house for long and comes to the facility, what antibiotics would you go first? Thank you.
Okay. So for this one, I will seek the assistance of the doctors who are with us to help us. Thank you.
Yeah, so I mean, what you are basically describing is, let's say she's not in labor and she ruptures membrane, so that's PROM. So you can go with our erythromycin, which we mostly give. You can also add flagyl, or you can even give amoxicillin if you have some. And the broad spectrum antibiotic, that's not contraindicated, but mostly you have to give erythromycin in whichever combination that you give. Is that fine?
Great. I think we have 3 other hands up. Nicolina, please go ahead and ask or make your contribution. Nicolina, I've asked you to unmute yourself. You need to press on the unmute button and then you can talk. Okay. Thomas, can you unmute yourself?
Good afternoon. Yeah,
All right,
please,
good afternoon.
Nicolina.
Yeah, please go ahead.
Please, I want to find out about the rupturing of memory. So, let's assume that the person is due for the 4-hourly vaginal examination. So, as you entered, you realize that memories was bulging. So, you have to do the amniotomy, or whether it ruptures spontaneously. I want to find out, normally we write the initials, either the ARM or the SRM. So I want to find out, are you supposed to write that initials exactly at the hour of your vaginal examination or before the time you did the vaginal examination? Because it's kind of confusing most of us. Like some will be like, you are supposed to write it before you plot the exact vaginal examination that you did, or you write it in alignment with the time that you did the VE. So I just want to find out. Thank you.
Okay. So please, rupture of membranes, being it spontaneous or artificial, you write it corresponding with the time that the membranes were ruptured, irrespective of vaginal examination. If the membranes ruptured at the time you did the vaginal examination, you chart it at that time. But sometimes you can do vaginal examination. Then 2 hours time, this one ruptures membrane. You write it corresponding with the time on the partograph. So the time the membranes ruptured or you ruptured the membranes is where you write it, ARM or R. So that is it. Please, is it clear? Stan Nicolina, please, is it clear? Can you hear me?
Yeah, I think Nicolina, yeah, she's gone off. You can type in the chat box if it's clear or any further question. We have someone as well. Thomas, can you go ahead and then make your contribution? Thomas Ako.
Hello, good afternoon.
Good afternoon.
Please. Hello, good afternoon. During the
Please go ahead.
presentation, under the contraindication, they made mention of second stage and then immediate complications. So we want to find out whether abnormal presentation and then multiple gestation are also part of. You can use photograph to monitor those cases. Because we didn't see it under the contraindication.
So you said multiple gestation. The literature that I have come across, multiple gestation, you can use a partograph. If it is breech presentation, you can use a partograph. In induction of labor, you can use a partograph. But those are special cases that you have to be extra vigilant with them. Multiple gestation like this, you only be charting the fetal condition for one twin. You can't chart for two twins on the partograph. So you are charting for one twin, but you are still being vigilant on the other twin, the condition of the other twin. So for the contraindications, a labor case that can make it vaginally, any labor that can make it vaginally, we are to use the partograph as a tool to monitor the labor. If anyone have something different, it is welcome. Thank you.
Yeah, so to add, Dinah is right. To add to what she said, yes. So for if the leading twin is breached, definitely it has to go to CS. But once it's cephalic, you monitor it on the partograph. The only difference is that you plot 2 fetal hearts where the heart rates are, because you're monitoring both the first and the second, but the distance and everything is the same. So you use partograph for twins, and then you can use partograph for breech as well. But if there are other abnormal presentations, of course, that one is for CS. Like if it's transverse and all that, you do not even allow them to undergo vaginal delivery.
See any other hand up? If you have any contribution, kindly put up your hand, and then you can. Otherwise, then we can close the meeting. There's a question in the chat box. Say good afternoon, bosses and seniors. Please, I joined late. My question from Abigail Kusi is it necessary to plot a partograph when the cervix is 8 cm dilated on admission? Thank you.
Yes, please. It is necessary to plot the pathograph when the woman is 8 cm dilated, because we have seen women who got to 8 cm dilatation and they never progress further. The labor can be arrested at that point. And if you did not plot it, you may not have the evidence to show that this woman came 8 cm. She was expected to deliver in 2 hours' time and she has not delivered. Thank you. Please, I hope you heard my response. Please, did you hear my response?
Yes. It was loud and clear.
Okay.
There are some
Okay.
2 other questions as well in. First one, how can you say membranes are ruptured but there's absent lipo? Then what exactly came out during the rupture? I'm at work and it's noisy here. So, okay, all right, that's fine. So she's saying that during the presentation, mentioned that the membranes were ruptured, but there was absent lipo. So what came out during the rupture?
So, yes, membranes can be ruptured, but liquor absent. A woman that you did not meet previously, who went through the ultrasound for the sonographer to diagnose that this woman liquor is finished. Recently, we had a case at my facility. She came and there was no liquor, which became an emergency. So the woman can come from the house. You just met this woman. Membranes can be ruptured. When she came, membranes were intact. Membranes ruptured. You did vaginal examination. No liquor. It is an abnormality. When there is no, we call it anhydramnios.
Great. So the next question in the chat box is, please, how about head in the vagina on arrival? Can a pathograph be used at that point?
No, please. I mentioned it in the presentation that a woman who have arrived with 10 cm dilatation, even if head is not in vagina, you cannot use a pathograph. So when the head is in vagina, you are preparing to deliver the baby. Thank you.
Excellent. Great. So we are done with all of the questions in there. I see a hand up. Habiba, please go ahead and then unmute yourself.
Hello, good afternoon, and thanks for the opportunity. Please, there's always this debate going on the wall.
Hand or is it?
Hello. Hello.
Go ahead.
Okay. Please, there's this debate always going on the wall. If V is repeated when it's not duly 4 hours, let's say membrane ruptured, then you need to repeat V when it's not necessarily up to 4 hours, the due time. So some say you don't require such findings in the pathograph, then it's always a debate in the world. I don't know if Doctor, you can add your inputs to that.
Okay. So when V is not due and membranes are ruptured, you are going to perform a V because you want to know the membranes that ruptured, is the liquor clear. That's the time you are going to check your molding and all that. Is there carpet? And then many times we see women who come and the time we are expecting them to deliver, they deliver before the time. So there's a possibility that the woman even became fully dilated before the next VE time. So if you check and the dilatation is not up to 10 cm, you do not plot it. You will wait. When the due time gets there, you do your VE again, and then you plot your cervical dilatation. The VE you did at the time membranes ruptured was for you to check other things like the membrane color, the molding, and all that. Thank you.
Yeah, I think you've answered it, but I think she's trying to say that sometimes you get when you see the dilatation and it's, let's say initially it was 4 cm, then she ruptured, maybe 2 hours later, I realized it was 6 cm. Should you plot it? The Partographs says you should do it every 4 hours, and this is meant to reduce the number of V's that you do that can lead to infections and all that. So if you are going to follow by it, then it should be 4 hours. But you can definitely note this somewhere because you did a V and you got, there are other forms of labor monitoring. You can note that at this point in time, when the membranes were ruptured, she was 6 cm dilated. And then at the time that you're supposed to do the V again, you do it and then you plot on your pantograph. So it's not really any big deal. Just note the V that you did due to some special circumstances in between the scheduled V's that is on the pantograph.
All right. So, Nicolina, are you still with another question, or is an older hand? Next
Please,
one is
no, dog. I want some clarification on something. I
go
think
ahead.
somebody asked that if the lady ruptures in the house, when they come, must you start the antibiotics? I want to find out, like, which duration. But you made mention of erythromycin and metronidazole. But can some also use the cephalosporin, like maybe cefuroxime and then ceftriaxone? Because I heard somebody mentioning of they have some line of drugs that are bactericidal and then bacteriostatic. So there is the erythromycin. Why should we start with the erythromycin and then the flagyl instead of maybe we can use the cephalosporin or either the cefuroxime with the metronidazole?
So if you have the cefuroxime, you can start this. I mean, it's broad spectrum enough. But the Oracle trial, that's a trial that started with realize that the erythromycin is better for the bacteria that is in the vaginal flora that can lead to you having chorioamnionitis and the rest. So you can buy if you have the erythromycin and flagyl, why not? Because flagyl cares for the interrupts. But if you have the cefuroxime and ceftriaxone as well, if that's what you have, you can start those ones.
So my last question: when the man comes and tells you that she ruptures, let's assume that 30 minutes.
Oh no, that is not. I was speaking in respect to prom.
Okay,
So
okay.
yes, that's what I was speaking in respect to. As in she came, she has ruptured me, but she's not yet in labor. But if she ruptured just before coming, oh, there's no point in giving antibiotics.
Okay, thank you, doctor.
All right.
Okay. Next is Abna. Abna, can you unmute and go ahead?
Okay, good afternoon. Please, my question is, let's say a client comes in labor and then she comes around in the morning around 7 and she's 4 cm and then she's being monitored on a partogram, but her contractions are maybe 1 in 10, lasting 20 seconds. And they are not regular. And then she's being monitored and she gets to around, let's say, maybe in the evening, and then she's now 8 cm. Membranes are intact. Please, can something be done for her to like increase the contractions, or you still monitor her? If still the progress is long, you just refer her.
Okay, so we are saying that the Partographs, you start when the woman is in active phase of labor. So when she is in latent phase of labor and everything is fine, there is no fetal distress, no maternal distress, you can still give the woman time. But when the woman is in active labor, but the contractions are ineffective or there are other problems, then an intervention will have to be taken place. Our doctors can add up if there is additional information.
Yeah, I think she drew a mental pathograph for all of us. That's good. But I mean, if you were listening earlier, you realize that from what you are saying, contractions 1 in 10.
Yes,
And yes, it's not progressing. So you've
yes.
realized that you've had to intervene with oxytocin. I think she mentioned that. You have to augment if the contractions are not adequate. If not, by the time she gets to the evening, she'll have crossed action line. And in that
Okay.
case, you need to refer.
Please, if membranes are intact, you can
No, you
augment.
rupture the membranes. You can rupture the
No,
membranes.
the membranes are not bulging for you to rupture.
Or you can augment. Once contractions are not adequate, it doesn't necessarily always mean that you have to rupture membranes before you augment. If contractions are not adequate, you can augment at any point in line when you realize that the contractions are not adequate and she's progressing through the pathograph.
With membranes intact.
Yes.
Okay. Okay. All right. Thank you.
Great. Margaret, go ahead. Okay, looks like Margaret is not on mute. Charles, please go ahead.
Yes, boss. Thank you once again. In our local setting where we have people who depend on this, what we term local oxytocin, that's causing hyperstimulation of the uterus. When they come, how do we intervene? Do we abort contractions? Do you immediately think of doing a cesarean section for them? Because some of them are grand multiples with very weak uteruses, and they come with hyperstimulation of the uterus. So what would you suggest is done for them?
Yeah, so Charles, you trying taxes to more than 5 contractions in 10 minutes, and you know they have taken. I heard it has some ergot component in it, which leads to the uterine hyperstimulation. I'll advise you to section to prevent any form of uterine rupture that might happen, or even fetal distress. So we've had quite a couple, and we normally section. But you can also try to alleviate those contractions if you can with some tocolytics. You can give maxofene, nifedipine, and all that. But if it is not aborting, you might have to section them.
Great.
We ever tried doing the aborting with nifedipine. It didn't
Yes,
work for I think 2 clients. So we had
that's what I'm
to
saying.
take in and
Yeah, to
bring
section
out
here. Yeah, it's good you took that
Yeah.
decision because the amount of, I mean, we don't even know the quantity that she took. So it might not even work if you try to abort. Yeah, so it's better to section them to prevent what will happen later on.
All right. Thank you, boss.
All right, great. I think that's the last question. We don't have Margaret. I see your hand is still up. I've asked you to unmute yourself.
Hello.
Hi,
Good
please go ahead.
afternoon. Yeah, please. I want to ask this question. When a client comes on admission and when she came upon assessment, she realized she was not in labor. Then the next day, she got into labor. Please, the time and the date on the pathograph, which one are you to record there? Is it the time on pathograph or the time of admission? Thank you.
Okay, so the literature that I was privileged to, the time that you place the woman on the pathograph and the date is the ideal. I don't know if there is different literature about it. If not, there will be contradictions. Yesterday, the woman wasn't in labor and went into labor today. So it means you were monitoring the labor yesterday, she delivered today. There will be contradiction. Thank
Yeah, so Dinah has really researched on this presentation. That's good. So the pathograph is for monitoring of active phase of labor. You see, there are some places that you have the latent phase monitoring and then the active phase monitoring. So when they are monitoring, she gets to active phase, in Ghana, say it's 4 cm. That's where you send her to the active phase monitoring room. And that's the time that you note on the pathograph. I don't know if that explains everything. So the time to which she comes to you. Of course, if she comes directly and she's 5 cm dilated. That's the time she came to you. So you put it on the Partograph. But if she was in latent phase, it will be monitored somewhere and then now came to you when she's 4 cm. It is when she entered active phase that you start. And that's the 4 cm. But if she comes 5, 6 cm, that's when you also that's why I also put on the Partograph. So that it doesn't create any confusion.
All right, great. I think that's the last question. And want to say a big thank you to Midwife Diana for leading us with today's presentation. Want to say a big thank you to Gildas, Dr. Gildas, as well, the obstetrician gynecology specialist. I see someone's hand has just gone up. Gifty, please go ahead.
Hello.
Or was it error? Yeah, please
Good
go ahead.
afternoon,
We're
please.
running out of time.
I don't know. I joined in not at the beginning. I want to find out on the plotting of the multiple gestation aspect on the fetal heart side.
So you plot
Hello?
2 fetal hearts. You plot 2 fetal hearts.
Okay.
You can do it if you look at it well. They will not, even if they are the same, they will cross at a point. But you have to plot 2 fetal hearts. That's the only difference.
Okay. Thank you very much.
All right.
Okay, so thank you so much for joining us for today. Thank you, Dinah, for an excellent job done. Thank you, Dr. Gildas, for enriching this presentation with your contributions. We are grateful to all the participants who joined us for today. I've learned a lot. I'm sure all of us who joined today would have learned a thing or two. Same time next week, we'll come your way with another presentation. I've put the links to our social media handles. By way of that, you'll be able to know the topics we are presenting. And then I've seen some people asking questions in the chat box about how to get the recording. The recording is put on our YouTube page. I've put that link as well in the chat box. So kindly click on the links that I've put in there, like the pages and subscribe to the channel, and you have all of these recordings. We are grateful for your time. Thank you for making this presentation an excellent one. Special thanks to Dr. Gildas, to Midwife Diana for this presentation. Have a great day and God bless all of us. Bye-bye.